Hello, and welcome to our program, RSV and the Older Adult, Much Ado About Something. This program is supported by an educational grant from Janssen Therapeutics, a division of Janssen Products. So before we begin, please take a moment and let us know who you are and answer the pre-polls in the tweets below. Tweets also include details of how to obtain your CME credit. And be sure to watch our handles for additional RSV CME programming and follow @BonumCE for more CME certified programs on Twitter. I am Dr. Falsey. I am an adult infectious disease specialist at the University of Rochester, and I have been studying RSV in adults for most of my career. And I'm joined by Dr. Ison. Can you introduce yourself?
Sure. My name is Mike Ison. I'm a professor in the divisions of infectious diseases and organ transplantation at Feinberg School of Medicine, and my career has been focused on respiratory viruses in hospitalized adults and immunocompromised patients.
Thanks, Mike. It's a pleasure to have you. And then we're also joined by Dr. Stephen Varga.
Hi, I'm Steve Varga. I'm a professor of microbiology and immunology at the University of Iowa and the Carver College of Medicine, and I'm also an associate dean in the graduate college here at the University of Iowa.
Thank you, Steve. Pleasure to have you with us. And so these are our faculty disclosures. So to get us started, we'll just review the learning objectives for the session. Upon completion of this educational activity, participants should be able to identify mitigation strategies to prevent exacerbations of RSV infection that contribute to increased morbidity and mortality. They should be able to differentiate the RSV vaccine product types in development for older adults, outline the efficacy and safety data of the late-stage investigational RSV vaccines, and then translate best practices for the management of RSV infection in older adults. So we're going to begin today with Dr. Varga, who will talk us through the mitigation strategies.
Thank you, Dr. Falsey. Today, I'm going to discuss RSV mitigation strategies. RSV is generally not considered an important health threat to adults. There are several reasons for this, including diagnostic challenges, underreporting, and underappreciation of the actual burden of RSV in adults. The underappreciation of the importance of RSV in this population is underscored by a quote that appeared on Twitter during the recent International RSV meeting held in Belfast, highlighting the fact that, quote, RSV may be the most important vaccine preventable disease no one knows about. However, RSV is increasingly recognized as a significant source of respiratory illness among older adult populations, particularly among those living with chronic health conditions. There are three primary goals inherent to any RSV disease treatment strategy. The first goal is to improve or reduce symptoms. The second goal is to promote rapid resolution of disease. And the third goal is to reduce transmission by decreasing viral loads. This slide is a reminder of the impact of RSV infection has on older adults. Notably, as shown in the figure on the right, RSV replicates faster and to higher titers in older adults than in younger adults. In addition, serum antibodies correlate with protection in older but not young adults, and immunity to RSV following a natural exposure wanes quickly and re-exposure occurs frequently in adults. None of the major US infectious disease societies or professional associations currently provide guidelines for the diagnosis, management, or treatment of RSV infection in older adults. The European Respiratory Society Task Force and the European Society for Clinical Microbiology and Infectious Diseases have guidelines which recommend molecular testing for RSV during the winter season, but make no recommendations on treatment. Mitigation strategies primarily revolve around contact prevention measures as recommended by the CDC, including hand hygiene, mask wearing, sanitizing surfaces, and isolating patients if they are in long-term care or healthcare settings, as well as avoiding touching the face with unwashed hands. There are a number of RSV therapeutics currently in development, including fusion inhibitors, nucleoside analogs, inhaled nanobodies, and siRNA. In addition, monoclonal antibodies are being developed for preventative use. This slide highlights several small molecule RSV fusion or F protein inhibitors that bind to the F protein of the virus and prevent viral entry into human cells. Rilomantivir is no longer in development, and EDP-938 is an N protein inhibitor, but is no longer currently in development. The development of RSV vaccines has been hampered by several things. One, the lack of an optimal animal model. Second, caution from previous experiences with the formalin inactivated RSV vaccines that were developed in the 1960s. Lack of serologic markers and correlates of protection, and a lack of long-lasting immunity, because as I mentioned earlier, reinfection with this virus is common. Other factors include difficulties with clinical trial designs and concerns that antiviral therapies are ineffective against virus-induced inflammatory cascades. Treatment goals for RSV vaccination efforts are to mitigate severe disease and complications in vulnerable populations where the burden of disease is high, including pediatric, maternal, and in individuals over the age of 65. Most vaccines in development are targeted at the pediatric population segment, since the burden of disease is high in this population. These vaccines usually utilize active immunization, where immunological priming confers protection. Maternal immunization offers passive immunity through transplacental transfer of RSV neutralizing antibodies. The goal is to confer protection for the infant's first 6 months of life. In older individuals with comorbidities who are also at risk for RSV-associated disease with multifactorial immunological pathways leading to severe disease that are not well understood. This often requires active immunization to stimulate greater immune responses in this population. On the right side of the slide is data compiled by Furtz et al. That looked at the clinical impact of a hypothetical RSV vaccine with 75% efficacy over 1 year time period in a target population of adults greater than 60 years of age. In both case scenarios, an RSV vaccine would prevent 2.4 million RSV ARD cases, of which 600,000 represent RSV lower respiratory tract disease cases. The results suggest that an effective RSV vaccine would substantially reduce RSV ARD and RSV LRTD cases, as well as RSV lower respiratory tract disease hospitalizations and deaths in adults greater than 60 years of age. This slide provides an analysis of the potential impact of an RSV vaccine in older adults. An economic model that used a decision tree framework was used to capture the potential clinical and economic outcomes of RSV infections occurring in one RSV season in US adults 60 years and older. It compared use of a hypothetical RSV vaccine for older adults versus no vaccine and based the outcomes assessment on a third-party payer perspective. The model predicted that vaccination results in avoidance of 43,000 to 81,000 RSV-associated hospitalizations, 8,000 to almost 15,000 deaths per year, and 1,800 to 3,900 fewer quality-adjusted life years lost, with an annual estimated savings of between 557 to 1,024 million in direct medical costs. The vaccine was predicted to be cost-effective at a range of $73.54 to $298.79, depending on the payer's willingness to pay. All right, with that, we'll start our discussion. I'm going to pose these questions for both Dr. Falsey and Dr. Ison. Why are some of the new therapies failing?
I'll take part of that question and address use in the non-immunocompromised older adult. And I think there are a couple of factors. One is timing of when people present for medical care. RSV very commonly presents initially as just a cold, and people don't seek medical care then. And on average, entry to the hospital or seeking medical care is then 5-6 days later. When, as we know from other antivirals, it's more difficult for that agent to have an effect. In addition, in adults, much of the clinical presentation can be dominated by exacerbations of chronic diseases such as COPD and heart failure, and that may be less amenable to control with an antiviral. But we do still worry that the virus has progressed from the upper airways to the lower airways in some patients, so it remains an unanswered question.
What influence does viral load or timing of diagnosis have on potential efficacy?
So the way that these antivirals work is by decreasing viral titers. And so the higher the viral load, particularly if you're in the upswing of viral replication, theoretically, these antivirals would work much more quickly. I think the other question that I've had is how much of the clinical disease that we're seeing is the direct result of the viral replication versus the inflammatory response to that replication. And much like other antiviral medications, the earlier the medication is started when you're in that upswing, that the more likely that the therapy is going to be effective in improving outcomes.
Great, thank you. Do you use any of the pediatric antiviral therapies off-label in adult populations?
Yeah. So the biggest one that I think people have thought about using is palivizumab. The big challenge with this is dosed for premature infants on a milligram per kilogram basis. And so for an adult, the cost would be tens of thousands of dollars. And so it's generally not used for those populations. Aerosolized ribavirin likewise was historically frequently used in immunocompromised patients, but again, because of significant increases in cost of this drug, this is being used less often in the adult population. And in fact, most centers, if they're using ribavirin, will use the oral preparations for treatment.
And Dr. Falsey, since there are no current RSV guidelines, what impact does that have on clinical decisions?
Well, the lack of guidelines certainly makes it difficult for the frontline provider because they really have to use their own judgment. Right now, since there are no specific RSV antivirals for use, it's less of a problem. But as new products are developed and vaccines, we will definitely need guidelines. So I'll be presenting the section on clinical management. And we would start by just addressing the fact that the clinical picture for RSV in older adults varies quite a bit, from essentially no symptoms to minor colds to bronchospasm, pneumonia, and acute respiratory distress. Asymptomatic presentation is actually quite uncommon in older adults when serologic studies have been done, probably less than 5%. As I mentioned previously, most will present initially with signs of a URI or a cold, with nasal congestion, rhinorrhea, maybe a little sore throat, and it's followed by more serious symptoms of lower respiratory tract infection, on average 3 to 5 days later. And these can include cough very frequently and wheezing with dyspnea. Chest x-rays are variable. They can be consistent with pneumonia, but when they are consistent with pneumonia, there are not dense pulmonary infiltrates. You might see some pulmonary nodules, some ground glass or wispy opacities, but it's not an impressive lobar pneumonia that you might see in a bacterial infection, unless, of course, there is a bacterial complication. The early presentation of RSV versus influenza does present with some general differences. I like to say that RSV is a very snotty, phlegmy, wheezy infection. So listed on this slide is nasal congestion, productive cough, and wheezing. And as mentioned, they are more likely to present with underlying heart failure, COPD, or exacerbations of other medical conditions. Whereas with influenza, we see more fever, myalgias and body aches, and chills. Now, while you can see statistically significant differences when you study fairly large populations of individuals. There's a lot of overlap between RSV and influenza and RSV and other seasonal viruses, and therefore a diagnostic test is really required. So in talking about the management of RSV in the older adults, in the outpatient setting, most individuals who are not immunocompromised are rarely treated with anything other than antipyretics and acetaminophen. As noted, there's a fair amount of upper respiratory symptoms, nasal congestion, and the like. And we have to use care when prescribing those agents to older adults, things that may cause exacerbations or worsening of things like hypertension. So some of the cold medicines that have multiple agents should be used with care in the older adults. Supportive care once somebody is ill enough to be in the hospital frequently involves bronchodilators because wheezing is quite common, supplemental oxygen, antipyretics, IV fluid because they may be so short of breath they're having trouble keeping up with their fluid intake, and rest. Noted here is antibiotics. So antibiotics are not standard of care with RSV, and the true incidence of bacterial complication is uncertain and really needs to be clinical judgment as to whether risk factors and signs and symptoms are consistent with a bacterial complication. So the major risk factors for a poor outcome and hospital admission include cardiovascular disease, multiple comorbidities with COPD and heart failure being very common, immunocompromised patients such as stem cell transplants, lung transplants, and solid organ transplant patients are also at risk, as are chemotherapy patients. Associations with higher mortality include cardiovascular conditions and greater than 2 severe immunodeficiency factors. So RSV does strike the immunocompromised host and those with comorbidities the hardest. It is a major cause of exacerbation of underlying lung disease, and in some studies and in some years actually results in higher hospitalization admissions than does influenza. In this data from Nelson Lee, RSV accounted for 35% versus 24% for flu. Multiple comorbidities, as we noted, is a risk factor, as are lung and cardiac diseases. Stem cell transplants and lung transplants are also very high risk, and at high risk to progress from the upper respiratory tract infection to the lower respiratory tract infection, with ranges of progression between 40 and 60%. Once lower respiratory tract disease actually develops, the morbidity and mortality can be very high, with in some studies mortality reaching 80%. The significant burden of RSV in these subpopulations is noted here, and 73% of individuals presented through the emergency room. So usually they go from their cold quickly to feeling quite short of breath and come straight to the hospital. The median length of stay was 6 days, ranging from 3 to 9. And most commonly, they were treated with supplemental oxygen and bronchodilators. Many individuals, because they come in with a diagnosis of exacerbation of COPD or asthma and are wheezing, they receive corticosteroids, and a large majority will receive antibiotics, whether they're needed or not. There was no significant difference between the groups as far as ICU care management. Confirmed bacterial infections occurred in 23% of the subjects, and this is remarkably difficult to do, to actually confirm with certainty bacterial infection, and this seems like a reasonable number. And antibiotics are more likely to be given to patients who are in the ICU. In looking at a retrospective chart analysis of risk over 2 RSV seasons, you can see here that antibiotics are shown in blue and ICU care is shown in green. You can see the high rates of antibiotic use, slightly less in the younger individuals. and ICU care was greatest among immunocompromised persons and persons with underlying lung disease. In persons who are immunocompromised, particularly transplant patients who are pre-engraftment, there are a number of agents which have been used, and these are all off-label. There is no FDA-approved treatment. Ribavirin is inhaled form, has shown modest benefits, but is terribly expensive. And oral ribavirin, while there's some concerns about how much drug will actually reach the bronchial secretions, has been shown to be non-inferior in some observational studies. Intravenous gamma globulin is typically given in combination with some form of ribavirin. And there is available high-titered RSV IG, which can be used in place of general IVIG, which may have variable amounts of neutralizing antibody to RSV. Experimental therapies, which were identified by Dr. Varga, are in development, and sometimes corticosteroids will be used.
Thank you, Dr. Falsey. The first question is directed at you, Dr. Falsey. Which subpopulations are of greatest concern for significant RSV burden?
So amongst our adults, it's those who are extremely elderly, generally over 75 or 80, or any adult with underlying medical conditions. And the greatest concern is underlying cardiopulmonary disease. And then lastly would be individuals who have compromise of their immune systems.
Dr. Ison, what is the best approach for determining whether a respiratory infection is RSV related?
Well, this really requires a diagnostic strategy. Clinically, it's very challenging to discriminate one virus for another, even with classic symptoms. While there's a range of ways of making diagnoses, the most reliable approach in adults is a PCR-based test. During the pandemic, I think we've seen a shift to broader use of PCR tests, while there's a lag in the transition from COVID only to triplex types of assays that look for flu, RSV, and COVID-19. Hopefully, as we're seeing this surge of all three viruses, this will drive increased use of these diagnostic strategies.
Great, thank you. Dr. Falsey, what risks or other factors must be considered when developing a treatment plan for RSV-related infections?
The most significant breakpoint in the treatment plan would be whether or not the person is immunocompromised and at high risk for mortality. So in the non-immunocompromised person, treatment is primarily supportive. And so then we break down as to whether or not there's significant bronchospasm, where one might consider using corticosteroids or bronchodilators. In the immunocompromised host, it has to be carefully considered whether or not they are at extremely high risk and whether they warrant some form of ribavirin, probably oral, and whether or not they would benefit from intravenous gamma globulin. And then the last thing is in the treatment plan must be considered whether or not there is reasonable concern for bacterial infection, because as we all know, antibiotics are not without risk.
Great, thank you. Dr. Ison, could you discuss some of the reasons why a number of the developed therapeutics have failed to progress?
Yeah, in general, the drugs that have failed to progress really haven't been able to demonstrate a clinical benefit in real-world settings. In most of the cases, there were earlier studies with experimental models where the patient was intentionally infected with RSV, and a short period of time thereafter, once you could detect the virus, the antiviral was begun. And those experimental models clearly showed a divergence in viral titer and clinical response to these patients. Because of the difference between these two models, one has to assume that it has something to do with the late timing of treatment in natural infection. But really, all of the different factors associated with clinical failure need further study.
Thank you. Dr. Falsey, which treatment options work best for mitigating poor outcomes in RSV-related infections?
If I might actually reword the question just to say which options, because we really don't have effective treatments that can mitigate poor outcomes in RSV infections. We talked a little bit about immunocompromised hosts and the use of gamma globulin and ribavirin, but I do think that the best mitigation measure is preventing the infection at all at this point. And we have learned some things about these mitigation measures from the COVID-19 pandemic. When RSV virtually disappeared, we also saw that when RSV made a comeback in the summer and fall of 2021, it really was limited to children in large part, without the usual surge in older adults. So I think what that tells us is we can be strategic in mask wearing, avoiding crowds, and good hand washing. We don't want to keep grandparents away from their grandchildren, but if you are very, very frail and have underlying diseases, when we know that these viruses are surging, it probably is a good idea to re-employ some of those measures.
Thank you both. And now we'll turn it over to Dr. Ison to talk about the current state of RSV vaccine development.
Well, I think as Anne just highlighted, prevention is probably the most important approach with RSV at this time. And we're in a very exciting period. After decades of clinical development, we appear to be on the cusp of hopefully having these available to help protect particularly our older populations initially, with hopefully future availability for other populations such as pregnant women and newborn children. There are a number of different RSV vaccines that are under development. And in fact, I think this is going to allow us to really learn a lot about the pros and cons of immune responses in different populations from the different vaccines. 2 different vaccines are currently under advanced development using recombinant vector vaccines, one with adenovirus, another with a modified vaccinia virus. There are a number of protein-based vaccines that are under development, mostly subunit vaccines with or without adjuvant. As we saw with the pandemic, there's a lot of enthusiasm for nucleic acid or mRNA-based vaccines. Lastly, there are live attenuated or chimeric vaccines that are less far along in development. So let's turn our attention to the vaccine pipeline for RSV vaccines in the older adults. We have a number of different vaccines, some that are still in the preclinical phase from Sanofi, CureVac, Vaxart, and BravoVax. A number that are moving into phase 1 testing, just looking at safety and immunogenicity in a healthy population. And then there is Moderna and Merck mRNA vaccines that are undergoing phase 2 testing. In the phase 3 arena, we have a number of different vaccines, some of which have reported preliminary data from their phase 3 trials, including an adjuvanted pre-fusion F protein vaccine from GSK, an unadjuvanted pre-fusion F protein vaccine from Pfizer, an adenovirus vectored RSV vaccine from Janssen, and then a vaccinia-based recombinant vector that is just starting clinical development. Since FDA materials will be submitted on some of these vaccines in the near future, hopefully many of these will become available for clinical care in the near term. One of the biggest things, and really the basis of basic science research driven by Barney Graham and others, was the recognition that the pre-fusion form of the F protein allows exposure of the most immunogenic parts of the protein to be present and allow the most robust immunologic response. Omicron at the very top, as well as Site 1, appear to be more readily accessible to antigen presentation in this pre-fusion form. And this form of the F protein is what is being incorporated in the majority of the vaccine strains that are under development. Well, let's start focusing in on some of the phase 3 studies that are under development. It's going to be important for us to go through some of the data, which we'll do after this initial summary slide. So as mentioned, there's a subunit vaccine that's being developed by Pfizer. It's completed and presented their phase 3 data with a vaccine efficacy of 85.7 to prevent severe disease as defined by 3 or more symptoms. The GSK adjuvanted protein vaccine, again, recently presented data from their first year of the phase 3 trial of 83% overall vaccine efficacy and 94% for severe lower respiratory tract symptomatology. And then Janssen was able to demonstrate an 80% effectiveness in preventing severe lower respiratory tract disease and a 70% efficacy for less severe disease. There's a human challenge study showing reasonable vaccine efficacy for the Bavarian Nordic, and the initial studies of the mRNA vaccine are just getting underway. Unfortunately, the Novavax vaccine failed to meet the primary efficacy endpoint, but did hit secondary endpoints. Well, let's start with the first of these vaccines, the RSV pre-FOA vaccine from GSK. This study has a study design which you are given a single dose of vaccine with pre-vaccine serology obtained, follow-up serology obtained about a month later. These patients are followed for development of clinical disease over the first season. And in this study and many of the others, patients will be followed over 2 more RSV seasons with randomization to those that got the vaccine in the first year, such that half will get a second dose, the other half will get placebo, really to assess the need for repeat seasonal vaccine. This was conducted as a placebo-controlled randomized study in multiple countries. The primary endpoint was the number of participants to have the first episode of PCR-confirmed RSV-associated lower respiratory tract disease during the first season. It also looked at a range of secondary endpoints shown in this slide. And as you can see, overall, there was vaccine efficacy of about 82.6% in preventing lower respiratory tract disease, 94% in preventing severe lower respiratory tract disease. Vaccine efficacy was preserved for both RSV A and B, was preserved in age groups. The age group of greater than 80 had relatively small numbers of patients and few breakthrough cases, and so really will need more data from subsequent seasons to inform clinical efficacy. What's really impressive with this vaccine and many of the other vaccines this will highlight is that the vaccine is very effective in boosting neutralizing antibody titers from baseline by about a full log. And then they also are very effective at increasing T-cell immunity, really representing the ability for these vaccines to result in both a humoral and cellular response. Moving on to the Renoir study. This is the study of the Pfizer vaccine, which was studied in a very similar approach as the GSK, where patients were placed into a randomized double-blind placebo-controlled trial. They received either a single dose of RSV prefusion or placebo and enrolled about 32,000 adults over 60 years of age. In terms of vaccine efficacy, they looked at patients with lower respiratory tract disease with either 2 or 3 symptoms, 3 being defined as severe lower respiratory tract disease, which had a vaccine efficacy of 85.7%. And you can see on the right-hand side that really it was symptoms of wheezing, shortness of breath, and tachypnea that really were what differentiated the patients between 2 and 3 symptoms, so lower tract disease and those with severe lower respiratory tract disease. The vaccine was able to cause increased boosting with response, although there was retention of reasonable levels of immunity 2 to 4-fold above the pre-vaccination level at all time points studied. There was a decay, but this was much slower after revaccination than the original vaccine. And both vaccination and revaccination were well tolerated and safe. Looking next at the adenovirus vectored RSV vaccine from Janssen, the Cyprus trial looked at vaccine efficacy in those patients with severe lower respiratory tract disease, those with greater than 3 symptoms, and had a vaccine efficacy of 80%. This was relatively stable across the different age populations and in those patients with underlying heart and lung disease with an efficacy of 60.3%. Again, excellent vaccine efficacy, even among those patients with 2 symptoms. There was persistent efficacy versus lower respiratory tract disease over 3 RSV seasons. So the vaccine efficacy in the overall population for seasons 2 or 3 was 76.1%, and across all 3 seasons was 78.7%. And this is really important to suggest that there's persistence of protection, which is robust and durable for both humoral and cellular responses. These data really supports single dosing over multiple seasons, and that the durability was not impacted by age or risk factors for severe disease. The Evergreen study enrolled 27,500 patients over 60 years of age. They were vaccinated prior to the RSV season and followed for 2 seasons. Again, very similar study design. They were vaccinated, followed for a year, and revaccinated to assess for adverse events and clinical responses. And this study is currently ongoing. The Nordic Bavarian construct using a vaccinia vaccine has undergone human challenge studies in which the patients are given either placebo or vaccine and then challenged with an RSV strain. From the virology, you clearly see a significant reduction in peak viral titers, as well as reduction in the number of patients infected, with a vaccine efficacy somewhere between 79 and 88.5%. This challenge model really does have result in relatively mild symptoms. Nonetheless, there were some patients that had moderate to severe symptomatology. And at least in this experimental model, you had a range of vaccine efficacy from 51.8% for asymptomatic disease, mild symptomatology with at least 2 positive PCRs of 76.2%, and moderate symptomatology of 79%. How this will perform in the real world is currently undergoing clinical trials with the design outlined here. They hope to enroll about 20,000 adults over 60 years of age in a randomized double-blind placebo-controlled trial. And really, this is the data that we'll need to have a better understanding of where we are in terms of efficacy. Lastly, the mRNA vaccine being developed by Moderna underwent phase 1 safety in older adults. It was definitely immunogenic in that vaccination resulted in significant boosting of antibody levels, and that persisted in patients over time with a very slight decay over the first 6 months overall. Vaccine recipients had adverse events which were generally mild and local in about 2/3 of patients. The most common systemic symptoms were headache and fatigue. The Conquer RSV study is planned to be a fast-track phase 3 trial, which will randomize 34,000 patients. There were 24,000 enrolled by early September, and really will help to assess these mRNA vaccines. So I'll turn it over to Dr. Varga to lead us through some discussion about vaccines.
Dr. Ison, are these data convincing to show RSV vaccinations can mitigate RSV-related lower respiratory tract disease and ARD?
Yeah, I do think that these studies that have been completed really do give us a lot of hope that these are very effective in reducing severe and standard lower respiratory tract disease caused by RSV. What's really interesting is if you look at the various different approaches that are used by the different companies, we're seeing protection in all groups with similar boosting of antibody and cellular responses. And so I think that this really demonstrates that these should be very helpful in reducing these complications.
Great. Dr. Falsey, are the study endpoints meaningful?
I think the study endpoints are meaningful. They are looking at, not just colds. They are looking at meaningful lower respiratory tract disease, in some cases, what would be considered severe with shortness of breath and wheezing. There has been some discussions that there should be included hospitalization and death rates, which are obviously quite meaningful as well. But I think if you prevent any respiratory infection and you can prevent moderate to severe respiratory infection, it only makes biologic sense you will prevent the more severe hospitalizations and deaths. Unfortunately, because of the pandemic, the rates of RSV infection in some of these clinical trials was a bit low. And so we're going to have to wait longer for more data, but I think these are very meaningful.
Great, thank you. Dr. Ison, what are your perceptions of the efficacy rates of the different products in phase 3 clinical trials?
Yeah, so I think that the ones that have completed phase 3 really show excellent protection, particularly against lower respiratory tract disease, and generally are within kind of a similar range. And so I think this gives us a sense that these vaccines will provide at least a similar level of protection.
Thank you. Dr. Falsey, Dr. Ison presented a number of different vaccines that are in development. Are there advantages or disadvantages to the different vaccine product types?
Well, there are theoretical differences. I would say the nucleic acid, the RNA vaccines are easily scaled up and are more easily manipulable. And so while that may be an advantage with influenza, which changes antigenically rather quickly, I'm not sure it's completely necessary with RSV, but it could be. The vectored vaccines tend to do a bit better with inducing robust cellular immunity, which may have some effect on durability. And the protein vaccines have been very successful at stimulating very high titers of neutralizing antibody. What that means for clinical efficacy and durability, we're really going to have to wait and see.
Thank you. Dr. Ison, what is the minimum efficacy threshold needed to consider whether to use one vaccine over another?
Yeah, so I think this is something that we're going to have to collect more data over time. What the absolute correlate of protection is for these vaccines is going to be essential to define, and really having protection, hopefully that persists over multiple seasons, will be a big strength. I think in the long run, one of the biggest things that we're going to have to think about is patient willingness to get 3 vaccines, flu, RSV, and COVID-19. If these need to be given at regular intervals, that means multiple vaccines in a year. And it may, while combination vaccines won't be likely available year 1, that when these are available, thinking how these can be combined to make a easier delivery, I think is going to be a bigger issue as long as they provide similar degrees of protection.
Thank you. Dr. Falsey, when can we anticipate vaccine approval and availability?
Well, I think within the next year or so, both GSK and Pfizer will be presenting to the ACIP, and FDA consideration will be coming along. And soon after that, Janssen is intending to present their data. How long after that we actually have product on the shelf, it's a little harder to say. But, I really do think we can feel confident in the next 1 to 2 years, we will start to vaccinate our frail and older adults with RSV vaccines.
It's a very exciting time. Final question, Dr. Ison, do you think vaccine strategies on the horizon will rely on single dose, multi-dose, or other strategies?
Yeah, I think it's for most of the vaccines too early to say whether you'll need a single dose, annual dose, multiple doses in the older adult population. I think that we clearly show that a single dose results in protective immunity for most of the studies. I think we'll have to collect more data across the range of studies to inform this in the future.
Thank you both so much, and I'll hand it over to Dr. Falsey.
Well, thank you. And I want to thank our audience for joining us today. Please make sure to claim your CME credits by completing the post-test evaluation form at the link on the screen. And please make sure to follow Bonham CE on Twitter to stay tuned for more RSV content. Thank you.